Welcome to the OMM-Medicine's module on GI scoring systems. So the first scoring system we'll talk about is called the Maddrey discriminant function, and this is going to be used to evaluate whether there is any benefit or not to giving steroids to patients with alcoholic hepatitis. And there are three major parts to determining the Maddrey discriminant function score, and these are going to be a PT, a reference range for your PT, and then a total bilirubin for your patient. So you'll plug these three components into a calculator and it will give you a score. And if the patient has a score greater than 32, it indicates that they have severe disease and there is a higher risk of short-term mortality, and therefore the use of steroids in this patient with alcoholic hepatitis would be indicated. Now, if a patient has a score less than 32, it would mean that they have a less severe case of alcoholic hepatitis and there is a lower risk of short-term mortality, and therefore you would not want to give these patients steroids. The next scoring system we'll talk about is called the MELD score, and the newer version is called the MELD-Na or MELD-Sodium score. And this is going to be used to evaluate the 3-month mortality risk in patients with end-stage liver disease. And in real practice, the MELD and MELD sodium score are really used to evaluate whether the patient is going to need a liver transplant. So the components of the MELD score is going to be creatinine, bilirubin, and INR, and then if you are calculating the newer MELD sodium score, then you would also include sodium. Now the scoring for the MELD and MELD sodium score are going to range anywhere from 6 being the lowest possible score all the way up to 40. And the higher the score you have, the higher chance of mortality you will have, and therefore the more urgent the patient will need a liver transplant. The next scoring system we'll talk about is the Child-Pugh Score, which is going to be used to assess the mortality risk in cirrhotic patients. This is somewhat similar to the MELD scoring system, however it uses different criteria. So the components for the Child-Pugh score are going to be the total bilirubin, the albumin, the INR, if the patient has ascites or not, and then whether there is the presence of encephalopathy. And when we talk about scoring for the Child-Pugh score, we can think of it in three broad categories. Those with a score of 5 or 6 will have a very good 1-year survival. Those with a score between 7 to 9 will have a moderate 1-year survival, typically in the range of 60 to 80%, depending on what source you look at. And then those with a score between 10 to 15 have a very poor prognosis, typically with a 1-year survival of less than 45%. The next scoring system we'll talk about is Ranson score, which is a very common scoring system to assess the mortality in patients with acute pancreatitis. Now the components of Ranson score are a little bit more complex, and it's typically easier to calculate just using a calculator, but it will use some items that are just present on admission, like the white blood cell count and your age, and all the other items we can see on the left side of the screen. And then it will also take into account how some of your labs have changed after 48 hours into your admission. So if you've had a greater than 10% drop in your hematocrit, if your BUN has increased by 5, or some of the other items that you can see there, these will all be taken into account to calculate your Ranson score. Now in terms of scoring, you can range from 0 to 11, and if you have a score less than 3, you have a very low chance of mortality, typically less than 3%. If you have a score between 3 and 7, you have a moderate risk of mortality, typically between 10 to 40%, depending on the source you look at. And if you have a score greater than 7, then you have a very high risk of mortality, anywhere from being greater to 40% all the way up to 100%, depending on what your actual score number is and also what source you look at. The next scoring system we'll talk about is called the Rockall Score, and it's going to be used to assess the risk of rebleeding and mortality in patients with an upper GI bleed. Now in terms of the components used to calculate the Rockall score, we can see them listed on this slide, and each of the major headings will also have their own subheadings. Now in terms of calculating a Rockall score, I don't think it's all that important to know each individual scoring section and how many points are associated with each, unless you are going into GI or you are doing your GI rotation. However, that scoring is going to be a bit out of scope of this video. Instead, I think it would be better to just have a general interpretation of what these scores would be. And so if a patient has a score less than 3, that has a relatively good prognosis for the patient with the upper GI bleed. And if they have a score greater than 8, then that would mean that they have a higher risk of mortality and a relatively poor prognosis. And the last scoring system we will discuss is something called the Rome criteria, which is a scoring system used to assess whether the patient's symptoms are likely due to irritable bowel syndrome or to another diagnosis. So there are technically 4 components of the Rome criteria. The one that typically needs to be met under all circumstances is that the patient is experiencing abdominal pain for 2+ days of the week for the last 3 months, and then you will also need at least 2 of the following 3 factors. So the symptoms that you are having will need to be either relieved or worsened with defecation. There will need to be changes in stool frequency, or there will need to be changes in stool form or appearance. And so if you meet 2 of those 3 criteria and you are experiencing the abdominal pain for 2+ days of the week for the past 3 months, then it is likely that irritable bowel syndrome is the cause of your symptoms. And just for completeness sake, we should mention that you can further subclassify what type of irritable bowel syndrome the patient is experiencing based on several other factors, such as the Bristol stool chart and what type of stool that the patient has. And that brings us to the end of this module on GI scoring systems.